Welcome to the presentation on case area targeted intervention to interrupt community transmission of cholera in humanitarian settings, reviews and case studies. Background: cholera remains significant cause of mortality and morbidity with majority of cases from sub-Saharan Africa and South Asia. Cholera is an acute bacterial diarrhea and transmitted by fecal-oral route through person-to-person and environment-to-person transmission pathway. Risk of infection is higher to those living in and near the case household. Early detection and quick response can contain the cholera outbreak. To interrupt cholera transmission in these high-risk environments, a set of preventive interventions are implemented. To interrupt the transmission, high-risk environments are identified around case household. A set of preventive interventions are implemented, including water sanitation and hygiene, health, and surveillance activities. These interventions, often referred to as CATI interventions, case area targeted interventions, or CATIs. CATIs are intended to be delivered to case households and immediate neighbors as early as possible after case identification. CATIs are often implemented through rapid response mechanism. The objective of this work was to study the process of CATI implementation, including alert system and flow of information, coordination between actors and sectors, and preventive interventions. Methods: we completed 2 reviews, peer-reviewed article review and grade literature review. For the peer-reviewed articles, we searched the articles in PubMed and Embase. For grade literature, Google search, Relief Web, technical implementing organization, and donor organizations' websites were searched. Key documents known to authors were included and forward citation tracking was completed. For inclusion criteria, for the peer-reviewed article, English published articles were included. For grey literature, English, Spanish, and French articles were included. Publication timeline was considered between January 2009 and November 2019. Primary data and systematic reviews were included. Modeling articles were not included. For inclusion criteria, reporting of cholera response and rapid response mechanisms were also included. We completed 4 case studies in Democratic Republic of Congo, Haiti, Yemen, and Zimbabwe. Consultation with the Strategic Advisory Group was completed to select these countries. The selection criteria was that past or ongoing cholera response and where CATI approach was implemented. Personal contacts and snowball sampling was used to identify the key informants. We completed 30 interviews, including members from UN agencies, NGOs, government branches, academics, who were involved in CATI implementation. The interviews were completed between June and October 2020. In the key informant interview, following topics were included: general information, background information, CATI activation mechanism, actors at organizational level, implemented activities, CATI composition, role, and trainings provided to the team members, CATI implementation rules, coordination, changes over time, changes in terms of activities, and changes in terms of team composition, both were captured. And then overall successes and challenges of the approach as reported by the interviewees. This diagram is showing the process of literature search. We identified 1,281 articles, and then from there we completed different screening steps. And from the peer-reviewed article, 11 documents are included, and then from grey literature, 8 documents are included in the final data extraction, in the final study. This table is showing the outbreaks that were included in this study. A total of 15 outbreaks were included from 11 countries, including 4 from DRC, 2 from Zimbabwe, 1 from each Cameroon, Kenya, Nigeria, Sierra Leone, South Sudan, Yemen, Haiti, Bangladesh, and Nepal. So I know this table is difficult to read. It is only included in the presentation to show the variation of different implemented activities. Each row is showing one activity. The activities were divided by activities that were implemented at the household level and then activities implemented at the community level. What we saw is that wash activities such as chlorine tablet distribution and hygiene promotions were more common, and health activities were not as common in wash activities. Team composition. CATI teams comprised of CATI team composition varied across outbreaks, and within the same outbreaks in Haiti and Yemen, teams comprised of staff from NGOs, government, and community volunteers. Commonly reported team composition comprised of 4 to 7 members with mixed set of skills, including wash, health, nursing, hygiene promotion, surveillance, and vehicle driving. Teams with only wash staffs were reported in Yemen, Zimbabwe, and during early response in Haiti, and individual health teams were included or reported in Yemen. Skill sets included in the CATI teams depended upon the type of intervention that was delivered in a particular outbreak. Alert system that was reported are a range of different mechanisms were reported. CATIs were multifaceted, involving numerous steps and multiple organizations. And a CATI is often started with an alert of suspected or confirmed cholera case. In Nepal, Bangladesh, South Sudan, rapid diagnostic test or RDT or culture confirmed positive test were reported. In Yemen, a combination of suspected RDT and culture test was reported. And in Cameroon, DRC, Haiti, and Zimbabwe, alert was generated when a case was presented at the treatment facility. Alerts were generated from line list by case reported by community health workers, and then also from media reports. The time between case identification and alert was critical for rapid implementation. Delays in sharing case information with the CATI team was reported in multiple outbreaks. And in some outbreaks, online tools such as WhatsApp groups were reported to expedite the information sharing process. Response. To response, if the total number of reported cases were more than the capacity of the CATI teams, a set of prioritization criteria was used in a number of outbreaks, including total number of cases reported from one area, areas without recent cholera cases, death of the patient, and then also if the reported case was RDT or culture positive. CATI teams traveled to the case household and implemented the interventions. Team lead decided the number of households to be included in the CATI, and the selection process depended on the density and arrangement of the households, implementation strategy, capacity, and then resource availability. The selection of household varied between only the case household, to up to 100 households around the case, and then from 50 to 100 meter radius around the case household. Evaluation of CATI was reported, and multiple measures were reported to evaluate the CATI performance, including timeliness, coverage, and cost of interventions, households' knowledge and practice to interrupt the cholera transmission, outputs such as items distributed during the interventions, and impacts such as incidence of cases. However, none evaluated the effect of individual intervention to reduce the number of new cases or interrupting the cholera transmission pathways. And then challenges reported where the common challenges that were reported are logistic challenges to implement the interventions, and then number of cholera cases were higher than the capacity of the teams, coordination among actors and integration of wash and health activities, access to target population due to insecurity in some settings, timely access to case information in order to rapidly implement the CATI, and then limited funding to adequately implement the interventions. So key recommendation from our case studies and from the literature review are establishing an alert system which will facilitate quick case identification, improved coordination mechanism between actors to share case information, effective integration between sectors in terms of team composition and also in terms of the interventions. And then studying effectiveness of interventions and establishing a set of context appropriate interventions to be implemented by the CATI team, and establishing standard guidelines for case and surrounding household selections. That's it. Thank you for your attention.